Finals SAQ67 Pneumonia. A. What is meant by the term ventilator-associated pneumonia? VAP refers to nosocomial lung infection occurring more than 48 hours after commencement of ventilation via endotracheal tube. This is in contrast to hospital-acquired pneumonia (HAP), which is defined as a pneumonia not incubating at the time of hospital admission and occurring 48 hours or more after admission without an association with mechanical ventilation. There are a range of different scoring systems to aid diagnosis that includes clinical, microbiological, and radiological factors. B. List the factors that increase the risk of development of VAP. This includes endotracheal tube. Endotracheal tube causes loss of cough reflex, biofilm development on the inner surface of the tube, and pooling of secretions on top of the ETT cuff that then gain access via channels caused by folds in the cuff. Nasogastric tube, which leads to bacterial colonization and predisposition to sinusitis, and therefore development of a pool of infected secretions on the cuff of the tube. Nasal intubation, which predisposes to sinusitis and a pool of infected secretions. Positive pressure ventilation, which forces microorganisms to the distal airways. Long duration of mechanical ventilation. Dysfunction in immune response associated with critical illness. Severe burns. Supine position. Low GCS or excessive sedation. And enteral feeding. C. What measures may reduce the risk of development of VAP? This includes avoidance of intubation, reduced duration of intubation where feasible, minimize risk of introduction of pathogens to the breathing circuit via hand hygiene, close suction, avoiding routine endotracheal suctioning, and limit disconnections in the circuit. Modifications of endotracheal tube design via inclusion of subglottic suction port just above the ETT cuff and tapered cuff of ultra-thin polyurethane to avoid channeling, antimicrobial coating of the endotracheal tube to discourage biofilm development, ventilator care bundle checked at each shift change, which includes nursing the patient 30 to 45 degrees head up. This reduces risk of aspiration, daily sedation interruption, which reduces number of ventilated days, facilitate more rapid weaning, and may preserve cough reflex. Histamine 2 receptor blocker, which reduces number of ventilated days, thromboprophylaxis to reduce incidence of venous thromboembolism, which in turn helps reduce ventilated days, oral hygiene with chlorhexidine mouthwash, and ETT cuff pressure check. Target 20 to 30 cm H2O or 2 cm H2O above peak inflation pressure. Ensure that the ventilator tubing is positioned so that the condensate does not drain into the patient. Overall, 44.3% pass rate. Additional Q&A. What is CAP? Community-acquired pneumonia is an infection of the lung parenchyma that has been acquired outside of a healthcare facility. Which patients with CAP should be admitted to the ICU or hospital? Those with a SAQ67 score of 2 should be admitted to the hospital, and those with 3 or more should be admitted to the ICU. Patients with class 4 or 5 pneumonia severity index should be treated as inpatients. Severe CAP is diagnosed when either one of the major criteria or 3 of the minor criteria have been met. Major criteria includes invasive mechanical ventilation and septic shock needing vasopressors. Minor criteria includes respiratory rate 30 breaths per minute or more, PF ratio of less than 250, multilobar infiltrates, confusion or disorientation, uremia, leukopenia, thrombocytopenia, hypothermia, and hypotension. Patients with severe CAP should be admitted to the ICU. Compare the etiologies of CAP versus VAP. Unlike CAP, where the predominant pathogens are pneumococci, atypical organisms, and viruses, 3/4 of the responsible pathogens in VAP are gram-negative aerobic bacilli and Staphylococcus aureus. What are the differential diagnoses of CAP? This includes acute bronchitis, acute lung injury due to sepsis, congestive heart failure, acute exacerbation of COPD, acute exacerbation of asthma, pulmonary infarction, lung cancer or pulmonary metastasis, acute exacerbation of bronchiectasis, acute exacerbation of pulmonary fibrosis, other lung infections such as tuberculosis or histoplasmosis, autoimmune disease with lung involvement, pleural empyema, and pulmonary toxicities due to medications. What techniques are utilized to identify the causative pathogens in patients with severe CAP? This includes gram staining and cultures of sputum and blood, Legionella and pneumococcal urinary antigens, and PCR assays for Mycoplasma pneumonia, Chlamydophila pneumonia, and respiratory viruses. What are the techniques that are utilized to detect lung infiltrates? CT lung is the gold standard technique to identify lung infiltrates. Limitations include increased cost, radiation exposure, and inconvenience of performing at the bedside. Thus, CT use is confined to presentations with unclear chest radiographs, and when entertaining differential diagnosis such as pulmonary embolism, fungal lung infection, and detection of complications such as lung abscesses in non-responding pneumonia. Ultrasound lung is a radiation-free technique and is safe for pregnant patients. It can be delivered at the bedside. Lung ultrasound has high accuracy in the detection of consolidation and pleural effusion when compared with chest radiography. A recent meta-analysis showed a sensitivity of 94% and specificity of 96%. Limitations include learning curve, repeatability, and operator dependency. Chest radiograph provides poor diagnostic accuracy of 49%, primarily due to a low sensitivity for detecting pulmonary infiltrates. How is select empiric antimicrobial therapy selected, and when is it implemented? How long should antibiotic treatment last? Empiric antimicrobial therapy is a broad-spectrum antibiotic treatment that is started upon CAP clinical diagnosis. This table shows the recommended empiric therapy for CAP in America, China, and Europe. The choice of empiric antibiotic depends on the most likely pathogen, individual risk factors, comorbidities, allergies, and cost-effectiveness. As soon as a clinical diagnosis of pneumonia has been made, antibiotic treatment should be initiated preferentially between 1 to 8 hours of hospital arrival, as a delay in antibiotics increases mortality. In severe CAP, antibiotic treatment should be started within 1 hour of diagnosis to improve mortality. The standard duration of uncomplicated pneumonia treatment is 5 to 7 days. The duration of antibiotic therapy should be adapted depending on improvements in symptoms and stability. Criteria for clinical stability includes temperature 37.8 degrees Celsius or less, heart rate 100 beats per minute or less, respiratory rate 24 breaths per minute or less, systolic blood pressure 90 mmHg or more, arterial oxygen saturation 90% or more, or PO2 60 mmHg or more on room air, ability to maintain oral intake, and normal mental status. Patients with CAP should not have more than one CAP-associated sign of clinical instability before stopping treatment. Patients may be switched from IV to oral therapy when they are hemodynamically stable, able to ingest medications, and are clinically stable. Patients with extrapulmonary complications or empyema, and those with specific pathogens such as Legionella or MRSA seem to benefit from prolonged treatment. One-time procalcitonin values lower than 0.25 mg per ml, or a decrease from the peak by 80 to 90% is a strong indication that antibiotics should be discontinued. How is therapy failure identified, and what are the patterns and etiologies of failure to respond? Clinical failure or a lack of response to empiric antimicrobial therapy within 3 days should be considered when patients with CAP presents with deterioration. Early failure, less than 72 hours, appears to be related to the severity of the primary infection. Late failures tend to be due to secondary events such as nosocomial superinfection and exacerbation of comorbidities. This box lists the etiologies of failure to respond to antimicrobial therapy in pneumonia. What are the risk factors associated with resistant pathogens in CAP? This includes comorbidities such as chronic lung disease, immune suppression, stroke, heart failure, diabetes mellitus, chronic kidney disease, previous pneumonia, cognitive impairment, poor functional status, and dysphagia. Patient status such as tube feeding and indwelling catheter, smoking and alcohol abuse, medications such as gastric acid suppression and previous antibiotic use, and previous infections such as MRSA and previous CAP due to resistant pathogens, and recent admission to the hospital or living facility are risk factors associated with resistant pathogens. What are the primary ways of preventing CAP? This includes influenza vaccines, smoking and alcohol cessation, respiratory hygiene measures, and correction of malnutrition and dysphagia. Comment on the epidemiology of VAP. Pneumonia is the most common nosocomial infection in ICU patients. More than 90% of these pneumonias occur during mechanical ventilation. However, the prevalence of VAP is overstated because post-mortem studies have shown that over half of the cases of VAP are false positive diagnoses. Mortality of VAP ranges from 0 to 65%. VAP-associated mortality rates must be viewed with caution due to the tendency of overdiagnosis of VAP. Can VAP be diagnosed with clinical criteria alone without microbiological investigations? Traditional clinical criteria to diagnose VAP includes fever or hypothermia, leukocytosis or leukopenia, increased volume of respiratory secretions or a change in character of the secretions, and new or progressive infiltrate on chest X-ray. In cases of VAP diagnosed using traditional clinical criteria, incidence of pneumonia on post-mortem is only 30 to 40%. Thus, diagnosis of VAP is not possible using clinical criteria alone and relies heavily on identifying a responsible pathogen via blood cultures, cultures of tracheoaspirate and bronchoalveolar lavage, etc. Blood cultures are only positive in 25% of VAP. Cultures of tracheoaspirates have similar sensitivity to bronchoalveolar lavage. However, cultures of BAL are more specific compared with those from tracheoaspirates. Describe the ventilator-associated events surveillance algorithm by CDC. This figure shows the VAE surveillance algorithm from CDC 2023. After a period of stability or improvement on the ventilator, which is defined as 2 days or more of stable or decreasing daily minimum FiO2 or PEEP, the patient has at least one of the following indicators of worsening oxygenation: increase in daily minimum FiO2 of 20% or more, or increase in daily minimum PEEP values of 3 cmH2O or more, then these patients are labeled as having ventilator-associated condition. On or after calendar day 3 of mechanical ventilation and within 2 days before or after the onset of worsening oxygenation, the patient meets both of the following criteria: temperature more than 38 degrees Celsius or less than 36 degrees Celsius, or white cell count of 12,000 or more cells per mm3 or 4,000 or less mm3, and a new antimicrobial agent is started and is continued for 4 qualifying antimicrobial days or more, then the patient is labeled as having infection-related ventilator-associated complication, IVAC. On or after calendar day 3 of mechanical ventilation and within 2 calendar days before or after the onset of worsening oxygenation, one of the following criteria is met. Criteria 1, positive culture of one of the following specimens, meeting quantitative or semi-quantitative thresholds as outlined in the protocol, without the requirement of purulent respiratory secretions from endotracheal aspirate, bronchoalveolar lavage, lung tissue or protected specimen brush. Criteria 2, purulent respiratory secretions plus organism identified from one of the following specimens: sputum, endotracheal aspirate, bronchoalveolar lavage, lung tissue, or protected specimen brush. Criteria 3, one of the following positive tests: organism identified from pleural fluid, lung histopathology, diagnostic test for Legionella, or diagnostic test on respiratory secretions for influenza, respiratory syncytial, adeno, parainfluenza, rhino, human metapneumo or coronavirus, then these patients may be labeled as possible ventilator-associated pneumonia. What criteria should be used to start empiric antibiotic treatment in hospital-acquired or ventilator-associated pneumonia? Together with clinical criteria and microbiologic cultures, the use of biomarkers is recommended, along with clinical pulmonary infection score, to decide whether to initiate antibiotic therapy. Useful biomarkers include procalcitonin, C-reactive protein, and soluble triggering receptor expressed on myeloid cells 1, STRAM1. To guide antibiotic treatment, one should rely on microbiologic samples or biomarkers. Microbiologic samples can be collected via non-invasive or invasive methods. When invasive quantitative culture results are available and below the diagnostic threshold for VAP, antibiotic treatment is unnecessary. The decision should be made based on prudent interpretation of the results when considering the specific clinical situation. PCT levels together with clinical criteria could also be used to guide discontinuation of antibiotic therapy. What are the principles of antibiotic use for VAP treatment? Empiric antibiotic therapy should be initiated early to avoid increased mortality. The choice of antibiotic should be broad spectrum, including coverage for gram-negative aerobic bacilli and Staphylococcus aureus, especially MRSAs. Popular regimens include tazocin, cefepime or acabapenem, plus vancomycin. Selection of broad-spectrum antibiotic treatment for VAP should be based on local antimicrobial susceptibilities if available, and should be a new agent for the patient. When a pathogen is identified, preferably within 48 hours, adjust antibiotics according to culture and sensitivity. Monotherapy is preferable to reduce antibiotic resistance. 1 week duration of antibiotic is adequate for most cases of VAP. For VAP caused by non-fermenting gram-negative bacilli such as Pseudomonas aeruginosa or Acinetobacter baumannii, 10 to 15 days duration of antibiotic is recommended. The duration of antibiotic should depend upon the rate of improvement of clinical, radiologic, and laboratory parameters. PCT has been used successfully with clinical criteria to guide discontinuation of antibiotic therapy. Consider also linezolid as an alternative for vancomycin for MRSA, colistin for carbapenem-resistant Acinetobacter, and aerosolized antibiotics. For patients with VAP due to gram-negative bacilli that are susceptible to only aminoglycosides or polymyxins, it is suggested to add inhaled antibiotics to systemic antibiotic therapy. It is also suggested to consider adjunctive inhaled antibiotics when IV antibiotic alone has failed to achieve high plasma concentration. What is multiple drug resistance? MDR pathogens are microbes that are resistant to one or more classes of antimicrobial agents. These pathogens are frequently resistant to 2 or more classes of antibiotics. Risk factors for MDR pathogen development includes prior IV antibiotic use within 90 days, septic shock at the time of VAP, ARDS preceding VAP, 5 or more days hospitalization prior to occurrence of VAP, and acute renal replacement therapy prior to VAP onset. What are the pathogen-specific therapy for HAP and VAP? For MRSA, antibiotic of choice is vancomycin or linezolid. For Pseudomonas aeruginosa and ESBL-producing gram-negative bacilli, antibiotic choice should be based on susceptibility testing. Options for Acinetobacter treatment includes carbapenem or ampicillin sulbactam if the isolate is susceptible. Tigecycline is not recommended. For species sensitive only to polymyxins, IV polymyxin, colistin or polymyxin B is recommended, and adjunctive inhaled colistin is suggested. Do not use adjunctive rivampicin. For carbapenem-resistant pathogens, treat with IV polymyxins if susceptible. Adjunctive inhaled colistin is suggested. What are care bundles? These are a group of evidence-based interventions that relate to a particular aspect of patient care. The strength of evidence supporting the individual components varies. Some elements may just be accepted as good practice. The aim of care bundles is that implementation of all the components together should result in better patient outcomes. Care bundles are readily auditable. Examples of care bundles include the VAP bundle as mentioned previously, the Hour 1 bundle for initial resuscitation of sepsis and septic shock from surviving sepsis campaign, Initiate bundle upon recognition of sepsis or septic shock, measure lactate levels, and remeasure lactate if initial lactate is elevated more than 2 millimoles per liter, obtain blood culture before administering antibiotics, administer broad-spectrum antibiotics, begin rapid administration of 30 ml per kg crystalloid for hypotension or when lactate is 4 or more, apply vasopressors if hypotensive during or after fluid resuscitation to maintain MAP of 65 mmHg or more. Example of care bundle to reduce surgical site infection is infection risk index calculation, preoperative shower, trichotomy, antibiotic prophylaxis, and body temperature control. How should parapneumonic effusions be treated? Options include thoracocentesis. This is advised for all parapneumonic effusions except for small free-flowing effusions in patients who are not severely ill or who are responding to antimicrobial therapy. To guide decisions regarding drainage of the effusion, send for pleural fluid gram stain and culture, pH and glucose concentration if pH is not available. Indications for tube thoracostomy drainage includes effusions that are large or loculated. Large effusions occupy more than half of the hemithorax. Purulent pleural aspirate, presence of organisms on gram stain or positive culture, pleural fluid pH of less than 7.2, and pleural fluid glucose of less than 3.3 millimoles per liter. Small bore chest tubes 10 to 14 French are advised because they are less painful and are as effective as large bore tubes. Intrapleural fibrinolysis can be considered for loculated pleural effusions or empyema to facilitate chest tube drainage and reduce the need for surgical drainage. Options include tissue plasminogen activator and recombinant DNase. Antimicrobial agents should be continued in the treatment of parapneumonic effusions. Surgical drainage should be considered when all other therapies fail after 5 to 7 days. Options include VATS and thoracotomy with pleural decortication. These are my references. Thank you.